Okay, let's talk a little bit about cardiovascular pathophysiology. And cardiovascular system, to me, is a lot like the nervous system in that there's so much information that we're really only going to get to cover the main principles and things you really absolutely have to know for this level of class. So remember, I'm going to cover the basics and help you understand how dysfunctions happen in the heart, but there's a lot of things you can look into beyond this class that are actually really interesting, and hopefully you want to pursue those. So first, just kind of think about some of the terminology or the wording that we use out in day-to-day life. Here's a pop quiz for you. So according to the NIH, what occurs when blood flow to a part of your heart is blocked for a long enough time that part of the heart muscle is damaged or dies? Is it heart failure? Is it cardiac arrest? Is it heart attack? Or all of the above, just the same thing? So think about the times you've heard this, and what do you think? Well, the answer is it's a heart attack. Yeah, heart failure is technically when you have reduced ventricular function. So it's when the ventricle is not working up to snuff. It's not pumping hard enough or moving blood flow enough, and that's heart failure. And we'll talk about congestive heart failure. Cardiac arrest is talking about the electrical activity of the heart. So if your heart stops its electrical activity, that's a cardiac arrest. But heart attack, that's when blood flow to part of the heart muscle is blocked. We'll talk about cardiac ischemia, where blood flows decrease and you're going to lose some of the function, and then slowly what's going to happen is that it's going to start shutting down. And of course the other name for this is myocardial infarction. So the correct answer is letter C. It's a heart attack. All three of these things are different terms for different events happening in the heart. So hopefully you're kind of curious. Heart disease, another reason you want to know about it is because it's the #1 killer in the United States. About 1 in 4 people that die in the United States are going to die because of heart disease. So another really nasty thing about it is about half of the men that die of heart disease didn't even know they had symptoms. So it's sudden, it just happens. And about 2/3 of the women who die suddenly of coronary artery disease die without knowing they had any symptoms. When you look at some of the patterns, every time I look at this chart, I always think, well, geez, look down by Mississippi. Look at all the heart attacks and heart disease that's going on here. And you just start moving up and away. And I always think of Paula Deen, the good old Southern cooking and what they're doing to their hearts. So look at the heart disease, look at the blood pressure. So you can see there's a direct relationship with things like hypertension and heart disease. We'll talk about some of the main factors, and it's not just because you have hypertension. Remember, because a lot of people that die of a cardiac event actually die without even knowing they had symptoms. So it's a silent killer too. Right. I adapted this from something I saw a long time online that was kind of a flow chart of events that have a tendency to happen as you're going from being what you consider to be healthy and having damage to the heart progressing all the way over until you actually have end-stage heart failure. Like I said, this is an adaptation, so it's a little bit tweaked for this class. But we're going to talk about each one of these steps along the way. We'll talk about the risk factors, what happens to your endothelial lining. Remember, endothelium is the inner lining of the blood vessel. It's the epithelial layer, the avascular layer. We'll talk about peripheral artery disease or peripheral vascular diseases like what happens to your veins. We'll talk about varicose veins. We'll talk about deep vein thrombosis. We'll talk about hypertension. So as you see, a lot of these problems, they actually build on each other. You damage the wall of the blood vessel. You get a peripheral vascular disease. That peripheral vascular disease affects your blood pressure, hypertension. And then that blood pressure affects the blood going into the heart itself, so the myocardium or the heart muscle. Coronary artery disease, we'll talk about having its impact on myocardial ischemia. We'll talk about valve dysfunctions and how they affect myocardial ischemia. And then we'll talk about angina, one of the key symptoms. So we'll talk about the chest pain that comes along with advanced myocardial ischemia or even with a heart attack. We'll talk about what happens when you actually have blockages to the flow to the heart, when you have an actual myocardial infarct, which means a blockage. So what happens when you block the flow? Ischemia is decreased flow, but the infarct is that you've actually stopped the flow completely and it's not flowing to the heart. And we talked about this the first week of class, when you stop the flow of the heart and all the events that happen, like your mitochondria can't get oxygen, you decrease ATP, of course it's muscle so it doesn't contract, and then you start producing reactive oxygen species. And then what's going to happen is you're going to start going through myocardial remodeling. You're going to change the way the muscle in the heart is. So you're going to remodel it, and that's going to leave some lingering effects. It'll actually leave effects like dysrhythmias or arrhythmias, so this is the electrical activity of the heart. We'll talk about what happens to the muscle itself. So ventricular dilations, talking about how the muscle doesn't contract as well, it doesn't stretch as well, so you actually start seeing a change in the overall structure of the heart. which leads to heart failure or congestive heart failure, where the heart doesn't perform as well, and then eventually what happens is end-stage heart and brain disease. So we'll talk about things like stroke, and we'll talk about what happens when you decrease blood flow, again, to the brain and the heart. So use this slide, and I'm going to put the slide in over and over and over again to kind of remind you of the different stages we're going through. And just let it be as a reminder. So the first thing we're going to talk about risk factors for what could be damaging the lining of the heart. A real key with remembering the lining of the heart is it's like Teflon. It's a non-stick coating. So as the blood cells, red blood cells, white blood cells, platelets, the plasma, the proteins in there, as they're sliding through there, it's a non-stick coating. You don't want it to stick. Because if you start damaging that wall, if you overstretch it from hypertension, if you cause it to build up with plaques, if you do anything that deteriorates that smoothness of the lining, things stick. Platelets start sticking, red blood cells start sticking, proteins start sticking to the wall, and then of course you build a clot that could break free and go downstream and actually cause bigger problems. So really what to remember here is that you want to keep your heart and your blood vessels, the endothelial lining, you want to keep it as smooth and perfect as possible, because as soon as you start introducing factors that damage it, you're going to have problems. So we'll talk about these first risk factors right now. And so here are some of the major risk factors, and some of these are uncontrollable, like your age, your race, your genetics. As we age, just natural time wears it down. It's like water eroding rocks, right? You're constantly pushing blood flow through the vascular lining. The beautiful thing is it's organic, so it can rebuild itself or repair itself. But the problem is that even with time and that abuse, it's going to start wearing down a little bit. It's going to start not wanting to retract. It's going to lose some of its elastic properties. It's going to have some damage that's going on. Race actually has a huge influence too. Like for instance, African Americans have a higher tendency to have hypertension. So if they have a higher tendency to have hypertension, they get more endothelial lining destruction or damage, which increases their chances of having a heart attack or heart failure. And then genetics, your parents passing down genes. One good example is actually just thinking about varicose veins. If your mother has varicose veins, you're likely to have them too. What's happening is that your blood vessel lining is just weak. It can't handle the pressure. Or that the collagen in your skin is not supporting those veins. But either way, we're talking about the collagen fibers that give structure to the blood vessels and to the skin that aren't as strong. So those veins start getting distended. Same thing with your artery walls. If you have weak artery walls, you have a higher risk of getting things like aneurysms. So there are some genes that you just can't avoid. So those are three things that are uncontrollable: your age, your race, and your genetics. Here are the major factors that are controllable. Hypertension, you can bring it under control. So you can change your lifestyle, you can change the way you eat, you can change the way you believe, you can adjust your stress. I know being in school you think that you can't adjust your stress, but you actually can. And there are things you can do that. So reducing hypertension is something that's in your control. Smoking, even in the slide, I love this little picture here where you see cigarette smoke and what it does. Once it gets into your bloodstream, all those toxins go into the tissues, they cause things to stick more to the tissues, they cause decrease in elasticity, which we'll talk about with the lungs. When your lungs can't stretch as far with things like damage because of smoking or carcinogens, they cause damage to the stomach or the lung lining. But here you have the reactive oxygen species, which have been a player all semester. You can see they can do things that damage the coronary arteries. They can affect your arteries. They can affect the blood vessels in your brain. They can cause weakness in spots. It may form aneurysms, which increase your risk of popping or bursting in blood vessels. Even the smooth muscle, they start having in their effects. So reactive oxygen species are a really key player, and that's why you want to have a diet full of natural foods that are high in antioxidants. You want to have a lifestyle that keeps your stress down so you don't introduce reactive oxygen species. You want to not take in things that we talked about back in the cancer section that increase the risk of ROS. Right? Insulin resistance we'll talk about just a little bit in a few slides, but when you have insulin resistance and you bring more of these sugars and factors into your blood, it increases inflammation. And inflammation is a key player in heart disease. So much so that they're looking for traces of inflammatory response in your blood to determine your risk for heart disease now. I mean, you used to hear the classic factors, high blood pressure, having high LDLs and low HDLs, but now they're also looking for things that are considered non-traditional risk factors, like inflammatory agents. Like I had you look up C-reactive proteins before that are related to inflammation. If you have higher degrees of those, you have a higher risk for heart disease. So insulin resistance increases inflammatory response. The same with obesity. Remember, your adipose tissues, we talked about this before, release pro-inflammatory factors. When those get into your system, they cause inflammation to the blood vessel walls, they cause damage to the tissues, and they increase the risk of things sticking to your blood vessel walls. So kind of keep these factors in mind, and you'll see that I'm going to keep coming back to these points all the way through these lectures. Look for the inflammation, look for the damaged wall, because that's the key to the beginning of the problems. Dyslipidemia is talking about not being able to regulate your fats in your blood, cholesterols, triglycerides, and we'll talk about that briefly too. And then back to the inflammation again. But they keep revolving around this inflammatory response. Remember, reactive oxygen species are actually part of that inflammatory response. Your neutrophils actually use ROS to destroy bacteria. They use, your macrophage use the same thing, a reactive oxygen species, to try and destroy invaders or to help clean up debris. So really, a lot of these problems revolve around you making these things. If you have a bad diet, if you have exposure to toxins, if you're a smoker, if you drink a lot of alcohol, all these factors increase your ROS, which increase damage to the endothelial lining. So I put this kind of slide that shows the relationship here. So hypertension, toxins, stresses, increased LDLs, dyslipidemia, you can see they all come along and they damage the endothelium. When you damage the endothelial lining, the platelets want to stick more. When the platelets start getting activated, they start creating these little scabs on the inside of your blood vessels, which cause, well, number one is, think about it this way. The drain in your sink is kind of like a blood vessel. If you start sticking things along the lining of that drain, what's going to happen to the flow? It decreases. So what's going to happen to your ability to perfuse tissues and bring blood flow and oxygen nutrients to the tissues? Well, it goes down. So what's the heart going to have to do to bring that back up? Well, it's going to have to work harder and pump harder. So you're putting more stress on your heart by damaging the endothelial lining. Right? And then again, you can see oxidation, so think reactive oxygen species. Every time you see oxidation, think it's some kind of reactive oxygen species. So it destroys it causes problems with LDLs, it destroys the endothelial lining. Right? When you have this destruction, this damage, then you have the immune factors that are coming in, like monocytes. They come in and they start eating away at this destructive product. Whatever the damage is, they're going to try and clean it up. Whether it's a plaque, whether it's a little piece of fat that slides underneath your blood vessel wall. So let's say you have some fat here and it slides under the blood vessel wall. Well, that shouldn't be there. So your monocytes come in and they try and clean it up. And we'll talk about that with atherosclerosis in just a few slides. Right? So overall what's happening is that you're creating scar tissue in the lining of the blood vessels, which thickens the wall of the blood vessel. And when you thicken it, it starts squeezing in on the blood vessel itself, which decreases flow. It's a chain reaction. Okay? That's pathophysiology. Right. So dyslipidemia, you want to think of fats. When you see lipid, it's not just one fat. It's things like your cholesterol levels. It's things like your triglycerides. So think about the process that's going on. You bring in fats into your diet. When you process the fats, they go in two directions. Right? So they go into the wall of the GI tract, and they can either go up to the liver, right? So they go to the liver and they get processed, or if you remember from physiology, they can be turned into chylomicrons in the wall of the GI tract and pushed into the lymphatics, which go straight up to your heart. So these chylomicrons are what we refer to as LDLs, HDLs. Sometimes you hear that they're referred to as VLDLs. It stands for low density lipoprotein. So you have this fat molecule and you stick these little lipoproteins, which are lipid proteins that make them a little bit more water soluble, right? Because fat hates water. So you stick this lipoprotein on the surface and it makes it more water friendly so it can move through your system. Well, a low-density lipoprotein means it's mostly fat, which means it's low density and it floats. It doesn't like being in circulation, so it has a tendency to cling to the walls. The HDLs, or the high densities, have a lot of protein on them, so they don't stick to the walls as well. In fact, when I was learning about this, what helped me remember is that you've got your liver that processes a lot of these things, and they put these lipoproteins on the surface, and you usually hear about the lipoproteins as being an ApoB or an ApoE or some kind of an Apo, and it just stands for apolipoprotein blank, whatever it is. Right, so you have these Apo products. They're going to stick these proteins to the surface of the fat to make it more transportable. Well, they go floating through the system, and if they're low density or very low density, they have a tendency to stick along the capillary walls, which is nice if you want to store them in adipose tissue, but what if it's in your heart? You don't want to store that in there. So if these low-density lipoproteins cling to the wall of the arteries in the heart, they'll actually move into the artery and they'll stay in the artery. But once they get into this wall of the artery, so here you see the HDLs and LDLs moving along, if those LDLs creep inside the wall of the artery, they like to hang out there and stay. They create these plaques, which we're going to talk about in atherosclerosis. So when you think of these, you really want to think of factors that affect your LDLs and HDLs are like your diet. Taking in too many fats, even if you have really good genetics that make you able to process these fats, taking in too many fats, you can still overwhelm yourself. Some people actually have genetics where they don't process fats very well. And those are the people that really get bad bad LDLs at young age. We'll talk about that a little bit too. So depending on your sex, male versus female, alcohol is really bad because alcohol makes you not able to regulate lipids appropriately. So I always hate saying that because I love a drink now and then. And what they've actually shown is that having one drink a day is pretty good because it helps you keep those lipids mobile and it helps prevent them from sticking into the walls. But having too many can actually cause other problems. So limit it to that one drink a day. Stress can do it too. Stress affects hormones that affect your ability to process LDLs and HDLs. And then things like thyroid, liver, or kidney problems. And I'll try and come back and talk about these a little bit later. But all of these factors affect your LDLs. Right? The overall goal is to keep your cholesterol, your total cholesterol under 200 milligrams per deciliter. So what they find is that if it goes over 240, it doubles your risk for heart disease. And when they say total cholesterol, they're actually looking at your LDLs and your HDLs. So they say you should keep your LDLs under 100 and your HDLs should be about 1/3 of your LDLs. So if your LDLs are 100, then your HDLs should be at least 33. Right? And I'm saying at least because they say with the higher HDLs, it decreases your risk for heart disease. And the theory is that the HDLs, they come along, and as they're running along the wall, and I'm kind of like oversimplifying this, but as they run along the wall, they actually pick up the extra cholesterol and carry them back to the liver where they can be processed. So having good HDLs or high HDLs actually helps you clean out the cholesterols from your system and the fats from your system. So LDLs, HDLs, and the last one are triglycerides, and those are just the fats that are floating around. They're not cholesterol, but they're another fat. When you eat a cheeseburger, we usually measure the fats as triglycerides. And remember, you can break triglycerides into free fatty acids and monoglycerides and then store them later. So that's dyslipidemia, is when you can't regulate these things, and there are a lot of factors that cause the inability to regulate. And LDLs, HDLs, and triglycerides are the keys you really want to watch. Right? So like I said, I would talk a little bit about genetics. And there's a disorder called familial hypercholesterolemia, and the name tells you it travels in families. They have too much cholesterol in their blood. And what it is they actually have a problem with that ApoB gene. They don't make enough of it. So if you don't make the lipoprotein, you can't stick it to the cholesterols. Well, if the cholesterols are just moving around as low-density lipoproteins or very low-density lipoproteins, they stick everywhere. They have a tendency to move into tissues and accumulate. And here you can see those LDLs are starting to move in, and they can actually stick along tendons. Like you can see this Achilles tendon is really thick because it's actually lined with cholesterol, which makes it weaker even. And then here you can see it accumulates in like the eyelids. You can see it along the knuckles. There's some accumulations. You can actually even see it on the eye itself. But they call these little cholesterol pockets, they call them xanthomas. It's spelled Xanthomas. So they're an abnormal growth in oma, but they're cholesterol abnormal growths. And here you can see again the HDLs and LDLs. The LDLs come in, they stick inside the tissue, and they cause these tissues to grow or expand out. The good HDLs come along, and they try and pick up the extra, but they don't always get enough. And people with this familial hypercholesterolemia, they make more LDLs than HDLs because they can't make those lipoproteins. If you only have a few lipoproteins on the cholesterol, then it's a low density. If you have a lot of those heavy lipoproteins, then you have the heavy density or high density lipoproteins, which are better. They can't make them. Right? So again, kind of going back to this theme is that watch the inflammation. All of these things that we've talked about this semester that can affect inflammation, like the kidney, your genetics, hormones, environment, these are all factors that affect basically your inflammatory response. If you don't get enough sleep, it increases your inflammation. You get the puffy eyes and just real nasty looking. So inflammation is kind of the key here. Going back to inflammation, cardiovascular disease, and endothelial function. Too much inflammation, you damage your endothelial lining, you'll lead to cardiovascular disease. So homework number 1, what is metabolic syndrome and how does it contribute to heart disease? So we haven't talked about diabetes yet, but metabolic syndrome is something we're going to talk about again later. What I want you to look at is what was the theme I've been talking about? What's metabolic syndrome contributing to this theme? Okay, endothelial dysfunction. So now we talked about the risk factors. Let's move up a little bit, and now we're down here to endothelial dysfunctions. What are the problems you can do to the blood vessels? And the first one is something called arteriosclerosis. And I'm stressing the name, arteriosclerosis, because it's an umbrella term for all the chronic diseases of the arterial system. So it's an umbrella term. You've probably heard of atherosclerosis, which is a subcategory of arteriosclerosis. So with arteriosclerosis, what happens is a couple major things. You can have plaques that build up in the lining. So like we just mentioned, fats can move in here, cholesterols can move in here, and it builds up a plaque on the inside. Or you can actually have calcium that accumulates in here, which causes a hardening. So you're looking at a theme here. You have a thickening of the arterial wall. I'm trying to get my mouse to move. You have a thickening of the arterial wall around here, and since it can't move out very easily, what it does is it moves in. Even if you have a thickening of this smooth muscle around here, it won't expand out so easily as it moves into this hollow core where there's not a lot of resistance. So arteriosclerosis is when you have the blood vessel lining that's expanding and moving into the lumen. What's it doing to the size? It's shrinking the radius or shrinking the diameter of this vessel. And if you remember from physiology, if you shrink the diameter of a vessel, what do you do to resistance? You increase the resistance, which decreases the flow, which causes poor perfusion to tissues. And the major problems we're going to look at are cerebrovascular diseases, peripheral vascular diseases, and ischemic heart diseases. So their major effects are going to be on the heart and the brain. Of course, after looking at the kidney and learning about the kidney, decreasing flow of the kidney is going to kill it too. It's like anything else. But the heart and the brain are the two primary organs you want to really worry about with arteriosclerosis. So let's talk about a subcategory. It's atherosclerosis. And here you can actually see a blood vessel, an artery, and you can see the plaques that are building up underneath. So atherosclerosis, what's happening is that you're building up or accumulating plaques just underneath the intimal lining. So the intimal lining is basically the endothelial layer, right? If you don't remember your terminology. And if you don't, you can go back to the last slide and look at the terminology all over again. But the plaques are developing. Here's how they're developing. So you can see a normal, nice, healthy blood vessel here. You get a little bit of damage or a little bit of reactive oxygen species going on here. The lipids start accumulating. What's going to happen are macrophages are going to come in and try and clear these up. But the macrophage, what they do is they just thicken. They get in here, they start eating the fats, and they start dying in there. They're creating this fatty plaque scar tissue material. And then eventually what could happen is you could have a rupture. And if this breaks, and you break the smoothness of that endothelial lining, clots start forming. And of course, clots can completely block off the blood vessel, or a clot can break free and move downstream, which we'll talk about in just a few slides. So that's atherosclerosis in a nutshell. Here's the actual progression. So you get this fat that starts moving into the wall, right? So fat starts moving in, and you start accumulating scar tissue. Well, that kind of weakens the wall, so the wall will start thickening up. It makes itself a little bit stronger, right? So it starts building this thicker, tougher, less elastic tissue. The mouse is just going crazy here. Less elastic tissue. And when the cells start proliferating, it's compressing or moving in, and it's smashing down the lumen, right? So now the macrophages are coming in full blown. Macrophages are coming in, they're trying to clean up all this debris, especially the fats. Well, the macrophages are just like us. If they eat too many fat, they don't want to move. So what's happening is the macrophage is eating so much fat in here, it just gets lazy and it stays there. Since the macrophage is releasing reactive oxygen species, you get this LDL oxidation. And they call these fatty streaks. You get basically these foamy looking cells, which are macrophages full of fat and reactive oxygen species. They start accumulating here, and they just get fatter and fatter and fatter. And now that you're trying to build up this fiber, and then eventually what could happen is you get this complicated plaque. Basically, it's so many factors. It's not coming out, by the way. It doesn't matter what kind of heart medication you're taking or what kind of Cheerios you're eating. This plaque stays in there. The way to fix this, or the way they usually fix this, is to put a balloon in here, and then they push it and they compress it even tighter, which doesn't really fix it. It's like patching a hole in the interstate, and if you live in Illinois, you know that just doesn't work, right? It comes back. So there's the progression, your pathogenesis of what's going on. Right. This is the Huether McCance pictures for this, but you can see the steps by steps. LDLs move into the wall. They start sticking in here. Macrophages come in. They try and clean it up. As they're cleaning it up, they release reactive oxygen species, which irritates all the tissue. Once they're full of fat, we call them a foamy cell, and they just lay there. They die there, and they stay forming that plaque. And that's atherosclerosis. This is kind of cool. This was actually researched in a mouse. What they did is these mice are knockout mice, right? So they take the gene that makes the lipoproteins and they turn it off. So the mouse can't actually make the lipoproteins to make the HDL. So all of its cholesterol is in a low-density lipoprotein or very low-density lipoprotein form, which mimics familial hypercholesterolemia, which means that the cholesterol is going to build up a lot faster. And they take these mice, and at different stages, you can see here at 10 weeks, you can see these atherosclerotic plaques already forming. And then by 40 weeks, and then at 80 weeks, it's just covered in the plaques. And you can see the thickening of the wall as it progresses. Now, I don't remember the age of a rat or a mouse, but a rat, when a rat's 3 years old, it's the equivalent of having basically a 70-year-old man. So mice probably age a little bit faster. When you're looking at 80 weeks, man, that's like half a lifetime. So that would be a midlife mouse or midlife rat right there at 80 weeks, having all that atherosclerotic buildup. So you can see the progression of the damage. And of course, what blood vessel is this? If it comes up and loops over, yeah, it's the aorta. And I put this in case you like more pictures, but here you can see the progression again. And this is in a human, not the mouse, but you can see the progression of the plaques, and then eventually a clot or a thrombus that blocks it up. Okay, so let's talk about that thrombus that I just mentioned. But a thrombus is just it's a clot inside of the artery. So what happens as you're building up, right, you've got this irritation to the lining, this rough area of the lining. Well, when the platelets and the red blood cells hit that, they start sticking around in here. And you've got this slow buildup or accumulation. One of two things can happen here. Well, I guess one of three. One thing that can happen is it slowly erodes off and the little tiny particles get broken off and you process them just fine. But the two bad things that can happen is that this can eventually just clog the whole thing. These are actually thrombi. So here's a long clot that was stuck in an artery. There's another long clot that was stuck in an artery. Right? So that's one thing, is it could just block up the whole artery. Right? The other problem is, what if it breaks free and moves downstream? So if it breaks free, now it's considered an embolus, and we call it a thromboembolus. So thrombophlebitis is when the tissue or the cell is actually inflamed because of this thrombus accumulating. So here you can see another one built up in the actual heart itself. Here you can see one where they're opening up and it was stuck inside the wall. So you can see all these different symptoms. When you get symptoms of it, what would you think would happen? If you're slowly clogging up an artery, what signs or symptoms would you expect? Well, whatever part of the body that was supplying blood to, what would you expect to happen to it? If it were going, let's say, to your brain, what would happen to your level of consciousness? It would just keep getting weaker, right? What if it were going into your heart? Your heart wouldn't want to contract as well, right? It'd have weaker heart rates, weaker heartbeats. So you can think about the symptoms. Wherever that clot's at, you really just want to think about it, right? Usually it blocks up flow before the clot. So the blood is going to back up down here. Well, if the blood's backing up, what's going to happen to the pressure here? It goes up. So now the fluid's going to be pushed out. As the fluid's pushing out into the tissues, what do we call that? Right, edema. So you usually see the edema behind the clot, where the blood's more at. You usually see atrophy or decreased activity of whatever tissue it is after the clot. So always think about where the clot's at, what direction is the blood flowing, and that'll give you your signs and symptoms. So you can have arterial, you can have venous. It doesn't matter. They can both happen, right? And an embolus, remember, an embolus is when it breaks free and moves downstream. So an embolus isn't just because of a blood clot. It can be anything that's floating in the blood that blocks up blood flow. So you could break a bone. And if you break a bone and a piece of that fat, so yellow bone marrow goes into your blood supply, it can move downstream and cause clots. There was an episode of House about that, of course. I think it was the last episode of season 5, maybe, where a woman had Crush syndrome. I think I mentioned this in another video. A woman had Crush syndrome, and a piece of her yellow bone marrow got into her circulation, went up to her heart, and killed her. Okay? So a lot of times where you see it go is if it's systemic, right? You're breaking a bone in your system, the blood gets into a vein, and it moves up into the heart. Well, the heart's a big chamber, so it usually doesn't stick there. Instead, it moves out of the heart and over, if it's in the right lung, going into the pulmonary circulation. Small vessels in the pulmonary area, so it blocks up the lungs. And that's kind of a theme. Usually emboli that happen in the systemic circulation will go into the lungs. Imagine this. It goes up through all of your systems into the right side of the heart, where you have the largest chambers. And then when it leaves the right side of the heart to go to the lungs, the chambers get smaller and smaller. The vessels get smaller and smaller. So that lump of particle, whether it's amniotic fluid, a piece of fat, an air bubble. That's what the little diver's there for, is because you can get nitrogen narcosis, where nitrogen gas forms a bubble in your blood vessels and it sticks in your brain and can kill you, stick in your lungs and kill you. Right? It can be cancer cells that break free. It can be a clump of bacteria that gets free. Any of these things are emboli. Right? So next is the myxoma, and the myxoma is a heart tumor. Right? The rare tumors. Why would you count on getting very few tumors in your heart and in your brain? I'm hoping you remember this. What do you know about heart cells and brain cells? Well, I should say neurons and cardiac muscle. Rarely do they replicate, right? So it's rare to actually get a tumor because you have to turn on all the genes to replicate in that situation and make this tumor. But about 50% of all the cardiac tumors are actually this myxomas. Roughly the other half are actually metastasized from somewhere else in the body, but these are a genuine heart tumor. And the problem here is that as they're growing, look at this thing growing up here. So this was expanding up in the right atrium, and as it's expanding, it's blocking off the flow. So blood has to come through, around, go down into the ventricle, and then back up. So a lot of times what they do is they block off the flow. And here you can see it again. This is a picture of the left atrium. But here you can see that tumor growing, and it blocks the flow. You could also get little thrombi accumulating around here that when they break free, they move downstream. And that's what this is that a clot had formed around the myxoma, and when it broke free, it actually moved up and clogged the arteries. And you see how long this clot is. It's kind of split here with this bifurcated and clogged both blood vessels. Right? So about half of the cases, well, 40% of the cases will actually form an embolism that could kill you. Right? Aneurysms, another problem with the wall of the arteries. So aneurysms, if you have weakening, and this can come with age, bad genetics, I already talked about this before, if you have a weakening of this blood vessel wall, it can actually start pouching out. It's just like a tire. If you slam the curb too hard with your car and it weakens part of the wall of the tire, you'll actually see that air starting to push out or bulge in that area. I guess not everybody's seen that, but you can do the same thing with balloons. If a balloon has a weak spot, that one area will actually bulge out. So it's an actual localized dilation. An aneurysm just means it's bulging. When you have a rupture, that's when you pop it, right? That's when people bleed to death because they've had an aneurysm rupture. A lot of people misuse that term, right? So you can have true aneurysms, and here you can see the terminology. So here you have fusiform aneurysms. The fusiform is kind of this bulge here. You can have a circumferential, which means it goes all the way around, or you can just have saccular, which is just one side. Right? Here you can have something called a dissecting saccular, where the endothelium breaks, and then as the blood pressure pushes, the pressure pushes inside of here. Look at the endothelium. It's all in a straight line still compared to these others. But now the blood's pushing in, and it's actually pouching out. So they call these dissecting because as the pressure pushes in here, it will actually peel the layers of the blood vessel wall apart. It dissects. And then false aneurysms, you look at the line, it's a perfect line, but you broke the wall, so a clot forms. So if you looked on like a radiograph scan, you might see a bulge here, but it's not a true aneurysm. It's actually a false one. It's just bulging in this area. Right? And then I mentioned aneurysms when they rupture. That's actually called a rupture. Most of the aneurysms you're going to hear about are going to be cerebral, or they're going to be aortic. High pressure. So pushing up into the aorta. You have thoracic, which is up here, of course, in the thoracic region, or abdominal. What's interesting is some of the symptoms. Sometimes you can actually feel your pulse in these aneurysms, and I've heard about this with older people. The blood vessel wall actually weakens with time, right? So if you have an abdominal aneurysm, every time the heart beats, it pushes, boof, 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 and you can feel all that pressure. It's not a straight line, nice smooth flow anymore. When the pressure pushes, it pushes out into the aneurysm and back. So as they get an abdominal aneurysm and that heart beats, they can feel their heartbeat down in their quote-unquote tummy, right? They can feel it down in their abdomen. If it's an abdominal, typically it's below the renal arteries. And if it's thoracic, it's going to be above. And technically, thoracic is above the diaphragm because, of course, that's the thoracic region. But here you can see, here's a cerebral aneurysm. You can see them bulging or pushing out. Typically, cerebral aneurysms happen around the circle of Willis, where you have most of that pressure. And they'll call little things like this berry aneurysms because they look like a berry. Right? Here you can see the heart. There you can see the descending aorta. You can see up here, this would be an abdominal. A thoracic aneurysm, totally blew out. Right? And then the causes a lot of time are atherosclerosis. If you build up a plaque here, and all that pressure starts pushing harder on the walls up here, you have a tendency to weaken the wall and it bulges out. So atherosclerosis, the hardening of the arteries. You can have hypertension, so high blood pressure, too much force. And that's one of the problems with African Americans is they get more aneurysms because they have more hypertension. And a lot of times it's a stroke, actually. So an aneurysm that pops in the head causes a stroke. We've talked about this before in other lectures. All right, local injury, so damaging the blood vessel here makes it weak. Diseases like syphilis can do this. So syphilis has a tendency to cause thoracic aneurysms, or used to, but now that we treat syphilis, it doesn't happen as much as it does. But natural aging is also a cause too. So weakening of the blood vessels. And here you can see different types. So there's thoracic. Here you can see an example of a cartoon of thoracic. Here you can see an abdominal aneurysm. And what's interesting is that a lot of people will actually die of other causes, and when they're doing an autopsy, they'll actually find aneurysms. Because as we age, our blood vessels get weaker, and if you can't support that, then you have a tendency to get aneurysms. As you get obese, it's harder to push blood flow, raising your blood pressure, increasing risk of aneurysms. And here you can see abdominal aneurysm too, so down below the kidneys. Obviously, these people didn't live through this. Right? And then valve dysfunctions. And I'm putting valve dysfunctions and endothelial issues because the valve is just an extension of the endothelium. So when you're looking at layers of the heart, you have the endocardium, which is the inner layer, which is just endothelium. It's continuous with the blood vessel walking all the way up. You don't want to break in that because then everything would stick there. So it actually bends over, turns into a cusp, come back in, and then continuous. So the cusp is actually silky smooth. If you remember when you were doing dissection and anatomy, how smooth and shiny it was. Just like Teflon, non-stick layer. You don't want anything sticking to those. So valvular dysfunctions usually referred to just as stenosis or regurgitation, and a lot of times they'll call this an insufficient valve. So this one doesn't open completely, this one doesn't close completely. And you can look at the primary places, aortic stenosis or mitral stenosis. So the aortic valve going into the aorta, which remember is a semilunar valve, or the mitral valve over here going between the left ventricle and the left atrium. I guess I could have said that the other way around, left atrium and left ventricle. Right? And then we'll talk briefly about this prolapse. But here you can see with stenosis, it doesn't open completely. So what's the heart, just common sense, what's it going to tell you the heart has to do? Well, it has to pump harder. So a symptom might feel like, you have this high blood pressure, you feel like your heart is pushing really hard. So there are a couple symptoms. It has a tendency to raise blood pressure and also puts more pressure on the heart. So those are a couple common symptoms. What's the common symptom you would hear if a valve were dysfunctional? So you put a stethoscope up to their chest or their back. What do you hear? Murmurs, right. Valvular dysfunctions have that unique symptom of murmurs. As we go through symptoms later, you're going to see that symptoms for heart problems are pretty straightforward across the board, but usually certain specific disorders will give you that one trademark symptom that really helps you identify it. And that's the key to learning all these diseases, is finding the one thing that really makes that disease unique. So here you can see some other issues. These are just a list of the valves, but here you can see calcified valves, and we'll show you this on the next slides too. So stenosed valve means it doesn't do what? Doesn't close or doesn't open. Its primary problem is it doesn't open completely. So the stenosed valve or valvular stenosis means that the valve doesn't open, which means the heart's going to have to push harder. What's going to happen to the heart muscle as a result? Well, it's going to thicken. It has to get thicker to push through that pressure. Right? And there's some common causes. Congenital is one. So sometimes you're just born and your valve doesn't open completely. It can be calcifications. So here you can see some calcifications, or sometimes they refer to them as vegetations, actually on it. And then another cause is rheumatic fever, where you actually get a strep infection that goes in. If the strep gets into the blood and it goes to the valves, then it can accumulate in the valves. You get this inflammatory response, and then basically you're building up scar tissue on the valves. It doesn't have to be just strep. It can be lots of different diseases. If you get sepsis, if you get any kind of bacteria, another common route for bacteria to actually get into your blood is through dental cavities or gum disorders, because you're chewing all this food that has bacteria on it, and you're pushing or you're forcing it down into your gums. So when you're brushing, your gums bleed, and then you eat afterwards, you just increase the risk of getting bacteria into your bloodstream. If you floss and you're bleeding, you eat right afterwards. If you get food jammed down in there, or you don't take care of your gums, it increases your risk for heart disease. Right? So I'm trying to think if there's anything else I really want to cover on here, but I don't think so really. Usually the symptoms here, you have irregular pulses. You feel faint a lot when you exert yourself. You just feel lightheaded because you're not able to push enough blood out to your brain, your other tissues. So you feel tired. You hear heart murmurs, right? Valve regurgitation. I thought I had another slide. Oh, I do. It's on the next one. So valve regurgitation means backflow. Normal valves, when they go to close, like up here in the corner, normal valves will flap shut and they create this tight seal. But what happens with regurgitation is that they don't form. So if you get scar tissue here and it kind of like shortens the length of the cusps, then every time they go to close, you get a little backflow, regurgitation. And when you're listening for a murmur, you can actually hear this gurgly sound. Where stenosis, it's more of a whistly sound. With regurgitation here, more of a gurgly sound, and I'm not even going to try and imitate that. Right? But causes, congenital, so the same thing. Maybe the cusps were born where they weren't, or you were born with the cusp not long enough. You can have valve deterioration, syphilis, an infection can come in here, rheumatic fever can do this too. Mitral valve prolapse is when the valve actually folds backwards. So normally when the valve is, when blood's squeezing, it's pushing up against the valve, it blocks the blood flow. But sometimes with prolapse, maybe one of the cusps folds in and then you regurgitate. Maybe the chordae tenonate aren't strong enough, or you're born without enough chordae tenonate. So the flap doesn't close completely, and that's called mitral valve prolapse. And of course, what valve is that? It's the mitral valve. What side of the heart is it in? The right or the left side? The left side. Which side has more pressure? The left side, so it has a tendency to push backwards a lot easier. But a lot of times the symptoms are the same. Fatigue, weakness, shortness of breath, irregular pulse, sometimes develops an arrhythmia, but definitely hear the heart murmurs. And a lot of times with regurgitation, you get swollen ankles and feet, edema, because the blood's flowing backwards. So that might be a unique feature you want to remember that might separate stenosis versus valvular regurgitation. You usually see more of an edema-like situation. And then infective endocarditis, I put this in here because we were already talking about endocardium. But what it does is it causes an irritation and inflammation to the actual lining. So if you have an infection, like strep again, so rheumatoid fever, it could be syphilis, it could be any bacteria, fungus, virus, anything that gets in and sticks to the heart wall will cause this vegetation. And they actually call it vegetation. So what's accumulating here are platelets, red blood cells, white blood cells coming in to take care of this, and they build this scar-like tissue, and they call that vegetation. Right? So these are basically microcolonies, platelets, fibrin, all stuck here together. And they'll cause things like heart murmurs, heart failure. They may actually cause petechial rashes if they start affecting the blood vessels. Not in the heart, but if they start affecting your blood vessels, like your capillary beds, they start destroying the capillary beds, and blood starts seeping out, and you can actually see that blood seeping. So here you can see some of the common places that you get endocarditis. So infective endocarditis. But it makes the valve really rough. Once you have that rough valve, you increase your risk for having thrombus and then thromboembolism form too. While we're talking about layers of the heart, remember there are three layers. There's the endocardium, the myocardium, which is the muscle we'll talk about later, and then there's the pericardium, the surrounding tissue. While we're talking about infections and layers, I thought this was a perfect place to put this. But pericardial disorders, they can be caused by different things. A lot of times when you get them, it will be after surgery when the heart's been exposed to an external environment. With infections, after a heart attack when it's already going through trauma and disorder. Tumors can cause it, cancers can cause it. But remember that pericardial sac is a fluid-filled sac that goes around the heart that reduces friction. You don't want anything compressing it. You don't want anything pushing into it. You don't want anything building up in it or on it, right? Because then it causes pressure on the heart that you don't need. So if fluid rushes in here, look at this. That fluid pressure can start squeezing on the heart, and they call that tamponade. So when you have pericardial effusion or fluid leaking in, it can put pressure on the heart, which is called tamponade, which means the heart can't fill completely, right? So it's putting pressure on it. When it's trying to fill, it can't expand because of that fluid's compressing on it. Pericarditis, acute, this is actually because of inflammation, so you get an inflamed sac around the outside. And this can actually last for like 6 weeks. And when you're listening for this, every time the heart beats, if you're listening with a stethoscope, they say it sounds like two pieces of leather rubbing against each other. So it causes chest pain, irritation every time the heart beats. And then constrictive pericarditis is exactly that. Something's constricting or smashing. Things like tumors, cancer can do that. I'm trying to think of something else, like scar tissue accumulating in the sac where it can't expand or move. Right. And then common symptoms of all of the above: shortness of breath, especially when you're exerting yourself because blood's not flowing efficiently through the heart or to the heart. They get fatigue really easy, especially with increased activity. A lot of times all of these things cause irregular pulses. If you have swelling, compression, not enough blood flow, you get these chest pains or irritatedness. Right? They feel faint. I feel like I already had that. Yeah, I did above. Heart palpitations, they feel like their heart's fluttering. Sometimes they feel like it misses beats. So sometimes they can feel the heartbeat. Because normally if you're just sitting here, you don't feel your heartbeat. Even if you concentrate on it, you don't feel it. But if you have an irritation, you have a problem. Sometimes if you just got done exercising, you can actually feel your heart beating in your chest. These are all common signs. And of course, heart murmurs are usually unique to having valvular issues. But these are all common symptoms telling you there's something going on with the heart. When we look at the heart diseases, here are the different types of heart diseases you really have to know. And we're going to list or walk through these. So problems with the heart muscle, coronary artery disease, heart failure like congestive heart failure, right congestive heart failure, cor pulmonale, inflammatory disorders, which we've already talked about 2 of them, valve disorders. So those are just the big picture. And then the last slide for this lecture is homework number 2. I want you to go to WebMD, symptoms of heart disease. So put exactly that in your browser, and then hit enter. And I want you to give me the one symptom that really makes each of these different. So what's nice is that WebMD made a whole list of all of these different heart disorders, and they give you a list of it. If you look, almost all the symptoms are similar, but each one has kind of a unique feature. So what I want you to do is write down the unique features for each of those. So what makes this different from that or that or that? And then you're not going to find cardiac arrest in this list, because cardiac arrest, remember, was stopping electrical activity of the heart. What you get every time with cardiac arrest, they pass out. So you don't have these symptoms, or you wouldn't observe it, and that's why they don't put it in the list. All right, so go ahead and do that, and we'll catch you on the next video.